This is Age-Related Macular Degeneration by Molly Locks. Introduction to eye diseases. Eye diseases are conditions that affect any part of the eye or structures immediately surrounding the eye. They are some of the most common conditions worldwide, affecting an estimated 2.2 billion people. Most are treatable, especially when caught early. Many conditions that affect the eyes are caused by or linked to other conditions affecting the body. Some of the most common eye diseases include cataracts, glaucoma, or age-related macular degeneration, or AMD, which we'll be exploring further today. There is an estimated $1.3 billion annual economic burden of vision loss and eye diseases in the U.S. Age increases risk of eye disease, and those who have identified as African, Asian, or Latino American are at a greater risk. Many of these diseases do not have apparent symptoms until they have progressed. That is why the dilated eye exam is performed so they can be detected and treated early to prevent vision loss. Most age-related eye changes begin to occur around age 40, but it is recommended that those who are 65 and older get an eye exam every year, and for those with chronic conditions such as diabetes or high blood pressure should go more often because they are more susceptible to eye diseases. AMD is an eye disease that can blur your central vision. It happens when aging causes damage to the macula, which is part of the retina that controls sharp, straight-ahead vision. AMD is common and the leading cause of vision loss for older adults. It does not cause complete blindness, but may make it harder to see faces, read, drive, or complete tasks like cooking. If a person has early AMD, they may not notice vision loss for a long time. That is why it's important for people to get regular eye exams. Here are the two different kinds of AMD. Dry AMD, also called atrophic AMD, is when the macula gets thinner with age. Dry AMD happens in 3 stages: early, intermediate, and late. It usually progresses slowly over several years. There's no treatment for late dry AMD, but ways to make the most of your remaining vision. And if you have late dry AMD in only one eye, there are steps to protect the other eye. Wet AMD, also called advanced neurovascular AMD, is a less common type of late AMD that usually causes faster vision loss. Any stage of dry AMD can turn into wet AMD. It happens when abnormal blood vessels grow in the back of the eye and damage the macula. There are treatment options available for wet AMD. Early AMD, there are no symptoms, and usually no symptoms in intermediate either, but some people have reported mild blurriness or trouble seeing in low light. In late AMD, wet or dry, straight lines may look crooked. There may be a blurry area near the center of vision, which over time may get bigger or cause blank spots in vision. And colors may even seem less bright than they used to. There is no cure for macular degeneration, but starting treatments early can slow the progression of the disease and make symptoms less severe. Even with successful treatments, symptoms often return. Depending on the disease type, treatments include nutritional supplements, medications, photodynamic therapy, and laser therapy. Anti-VEGF medications are used to treat people with AMD, but the necessity of long-term therapy and the frequency of injections place a substantial financial burden on both individuals and the healthcare system. Epidemiology. Risk factors include age 55 or older, family history of AMD, being Caucasian, or smoking. In 2019, an estimated 19.83 million Americans were living with some form of AMD. This is 2.75 times higher than previous estimates. An estimated 18.34 million Americans had early AMD, and 1.49 million had the late-stage AMD. About 1 in 10 Americans aged 50 and older have the early form of AMD, and 1 out of every 100 aged 50 and older have the late form of AMD. Among people 80 and older, approximately 3 in 10 had early AMD, and approximately 1 in 10 had the late form of AMD. Gender and age standardized rates of the disease were lowest for African Americans as compared to other race/ethnicity groups, while rates were the highest in the Midwest and New England regions of the country and in Florida. Now for pathophysiology. The pathogenesis of AMD includes oxidative stress and retinal inflammatory pathways. After the development of new blood vessels in the retina and subretinal region, dry AMD may evolve into wet AMD. These arteries result in bleeding, serum leakage, fluid retention, visual distortion, and central vision loss. As a result, mitochondrial dysfunction, altered proteostasis, altered lipid homeostasis, and lack of cellular control of oxidative stress combine to create an internal feedback loop that leads to the failure of the RPE and the accumulation of abnormal proteins and abnormal lipids that will eventually form drusen. Over time, drusen material is more likely to accumulate due to insufficient antioxidant defenses, deficiencies in autophagy systems, and dysregulation of the extracellular matrix. Once the region becomes chronically inflamed, the drusen operate as inflammatory centers that recruit macrophages to the area. Outcomes of the dry form include progressive vision deterioration, geographic atrophy, and slow but steady degradation of the outer retina, causing vision loss. Here you can see how environmental factors like high-fat diet or smoking, aging, and genetic factors play a role in oxidative stress, leading to inflammation and eventually AMD. Please take a moment to pause here if you would like to continue reading the graphic. Now let's take a look at studies that investigates lutein. This is a follow-up study of a 2001 AMD study that showed vitamin C, vitamin E, zinc, copper, and beta-carotene reduced the risk of progression for AMD by 25%. This study wanted to examine lutein and zeaxanthin because they are carotenoids that are naturally present in the retina and considered safer than the beta-carotene that was linked to increased lung cancer risk in those who smoke. They are traditionally marketed to support eye health. They also wanted to study omega-3 fatty acids due to observation evidence that suggests it has protective effects on AMD because of the DHA being a major structural component of photoreceptor cell membranes in the retina and EPA involvement in anti-inflammatory properties. The carotenoids are used because they can neutralize free radicals and reduce oxidative stress in the retina. They are macular pigments. They accumulate in the macula where they can filter harmful blue light, reducing light oxidative damage. The participants were aged between 50 and 85 years old. There were 4,203 of them, selected because they were high risk for progression to advanced AMD. This was a follow-up study about 5 years later, and only 141 participants did not come back, while 368 died over the study period. It was a randomized, double-blind, placebo-controlled trial. In addition to the standard supplement, they were given 10 milligrams lutein, 2 milligrams zeaxanthin, and 350 milligrams DHA plus 650 milligrams EPA daily, and a secondary randomization of removing beta-carotene. It was hypothesized that adding lutein and zeaxanthin plus omega-3 could provide additional protective benefits beyond the original formula. However, the study did not find a strong overall benefit in adding both the lutein and omega-3s for all participants compared to the placebo, but there was a statistically significant reduction in progression to late AMD for those with the carotenoids versus those without. Lutein/zeaxanthin may be a more appropriate replacement for beta-carotene, especially in those with certain risk factors such as former smokers, due to the safety aspect. This trial had 3,882 participants. It was another 5-year follow-up to the previous study, and they plan to assess if there is a benefit of adding lutein/zeaxanthin to the original supplement that can be observed with long-term follow-ups. The intervention is all participants received a supplement containing the lutein, zeaxanthin, plus vitamins E and C, zinc, and copper. The results showed that there appears to be safe and effective long-term substitute for beta-carotene, and it may even offer slightly greater reduction in AMD progression compared to beta-carotene. This study had the intervention of 20 milligrams lutein to see if it would affect the macular pigment optical density, or MPOD, in 39 Japanese patients who had unilateral AMD over 6 months. They also compared 2 different capsule types, beeswax versus glycerol fatty acid ester, to see if the capsule material affects lutein absorption. The measurements include MPOD, plasma lutein concentration, and contrast sensitivity under glare and low light conditions at baseline, 3 months, and 6 months. The results showed there was a gradual increase in MPOD over 6 months, but it was not statistically significant for the overall group. The beeswax group had a greater increase compared to the other capsule group. Plasma lutein significantly increased from baseline to 3 months and baseline to 6 months in both groups. There were no significant improvements in contrast sensitivity over the 6 months. This shows that even if lutein accumulates in blood and maybe in the retina, it didn't translate into measurable functional vision gains in this short time frame. Now for the evaluation. The long-term trials showed a positive association between lutein and progression of AMD. However, the short-term trials may have been too short to tell. These were all randomized double-blind trials. The first 2 had a large sample size, while the second only had 39 participants. And there may be population bias with the certain stages of AMD that they looked at. Now to examine vitamin D. In AMD, chronic inflammation and dysregulated immune responses are believed to contribute to disease development, while vitamin D has anti-inflammatory and immunomodulatory effects and may inhibit abnormal blood vessel growth. While there were other prior observational studies that suggest an association between low vitamin D levels and increased AMD risk, they were cross-sectional or case control, so they couldn't prove whether low vitamin D preceded AMD or if AMD caused lower vitamin D. This cohort study had 1,225 participants aged 45 to 65 years at visit 1 and recruited from 4 centers in North Carolina, Mississippi, Minnesota, and Maryland. The methods for the analyses include participants needed to have available serum 25D concentrations from blood drawn at visit 2 and gradable retinal fundus photographs taken at visits 3 and 5. Results: people with the highest levels of vitamin D in their blood had a 40% lower chance of developing early AMD compared to those with the lowest levels. The study, however, did not find a strong effect for vitamin D levels on advanced AMD, as there were only a few cases. The study had 2,146 participants for over 9 years. They looked at how much vitamin D from foods and supplements people consumed and whether that was linked to progressing from early or intermediate AMD to advanced AMD. They also looked at calcium. The dietary data came from food frequency questionnaires, and the results include people in the highest quintile of dietary vitamin D intake had about a 40% lower risk of progressing to advanced AMD compared to those in the lowest quintile. And people who had high vitamin D but low calcium intake had an even lower risk of advanced AMD compared to those who were low in both. Here we have a randomized controlled trial where they took either vitamin D or placebo and omega-3 or placebo. There were 25,871 participants in the follow-up of about 5 years. The outcome measurement was total AMD events, including both new diagnosis of AMD plus progression in people who already had AMD. There were 324 participants that experienced an AMD event in the 5 years. 285 were incidence AMD, and 39 progression to advanced AMD. For vitamin D, there were 163 events in the treated group and 161 in the placebo group. For omega-3 group, there were 157 events in the treated group and 167 in the placebo group. So neither vitamin D nor omega-3 fatty acid supplementation had a significant overall effect on AMD incidence or progression. For the first and second study we looked at, even though they measured vitamin D prospectively, it's still possible that unmeasured confounders explain some of their findings, and neither were randomized trials. The second study was a long follow-up and did account for calcium as a confounder, but food frequency questionnaires can be wrong. The third study was randomized controlled and found no association between vitamin D and AMD incidence or progression. And here are the recommendations. It is always important to talk to your healthcare provider prior to starting a supplement. And with the limited research done on the vitamin D supplementation in relation to AMD and the randomized control trial not supporting its effect on AMD, it is not recommended as a therapy for AMD. However, lutein has shown promising long-term effects on AMD and its protection of the retina from blue light and oxidation, so it may be considered for those who are at risk of or diagnosed with AMD. This would be recommended with the vitamin C, vitamin E, zinc, copper, and zeaxanthin as part of a supplementation as well. And other therapies to consider when thinking of AMD is curcumin-based nutritional supplements. This is a cohort study that aimed to investigate whether using curcumin-based nutritional supplements, or CBNS, which are known for anti-inflammatory and antioxidant properties, is associated with the risk of developing or worsening AMD. The participants included patients without a history of AMD to study incidence and patients with early AMD to study progression, and identified whether they were taking CBNS versus those not taking it. Outcomes measured were dry AMD, advanced dry AMD, wet AMD, blindness, and need for intravitreal anti-VEGF therapy. And among patients 50 years or older without AMD, CBNS was strongly associated with lower risk of measured outcomes. Among patients with early dry AMD, CBNS prescription was associated with reduced progression to advanced AMD. The study suggests that CBNS use is associated with a reduced risk of developing AMD and slower progression of early AMD. So thank you all for listening. That's all I have. Lastly, these are my references.